So, thank you very much, Megan, for introducing me. So before, that was a bit about me. Before we sort of get too much into it, can I just get an idea of where you've worked, what your sort of current level is, how many years out, and that will sort of change how I
Wow.
start on this side.
Panicking.
Wait till you've got a mouthful of stuff. Just really quickly, I hate all these intro things on courses, but we'll do it anyway.
Yeah, so I've been out for 2 years and I was working around Rockingham, Baldivis, and then I started here at the beginning of the year.
Okay, mainly private practice?
Yeah.
Musculoskeletal?
Yeah.
Okay.
6 years out.
Yep.
I worked in Bayswater and High Wycombe for 3 years, then I took 18 months off, and then I went to Canada for 18 months, and then and didn't do any physio, and then back here for a year. All private practice.
And it's all private practice, musculoskeletal?
Yes.
So I've been out since '94.
Yeah.
On there.
I was born in 96.
Oh my gosh.
Yeah.
And I did a couple of years at Freo Hospital, actually doing all areas of physio, and then I worked in private practice in Perth for a few years, and then in London, and then ended up in Melbourne in private practice, and then when I had my children I had a few years off, and I've been back, and I did a Pilates rehab course, and then I've been working for me for about 3 years. Nearly 3.
Okay.
Yeah.
Alright, so obviously there's a difference there in experience and what have you, so hopefully I'll try and
I have
make sure.
had a bit of time off though. So
Hopefully I can make sure everyone gets something out of it.
Yeah.
So there is a little bit to get through. So this is going to be session 1 of 2 sessions. So we're going to do 2 hours now and then in a couple of months' time.
On the cervical spine.
On the cervical spine.
Mm.
So it's not all going to happen in this session. There is quite a bit to get through. So if you think about the things that you probably need to know for the cervical spine, we could easily do a weekend on it, and the level 1 cervical spine would probably be a weekend, and the level 2 would be another weekend. So we can mix and match a little bit to make sure that you get a good overview of what you need to know, but I'm probably going to focus on some fundamental stuff. I think it's going to stand you in good stead.
Mm-hmm.
So a little bit about me. That's where I'm from in the UK, from the very southwest. I did my undergraduate at the University of Wales in Cardiff, and then I moved over here in 2009, and I did my masters in 2010, I think it was, and specialisation over the last sort of 2.5-3 years. So just a little bit of an overview of what we're going to look at. So we'll have a bit of a talk about neck pain, a few slides on that, just the kind of stats around it. I think the key thing, which is why I sent out one of those articles, I don't know if everyone managed to read it, the Bogduck one on the cervical spine, it's the biomechanics of the cervical spine. So we'll look at that because that's going to guide how we assess and what we look at and how we treat as well. I think with anything around the cervical spine and head, getting a sort of a fairly solid neurological exam is a good idea, but we're not going to look at cranial nerves. I think that's sort of like something that we're aware of from uni days, but cranial nerve testing, if it's done properly, is a little bit more complex, and that's probably beyond what we're going to do now. We'll discuss VBI and CAD, so vertebral basilar insufficiency, probably more common with, and CAD, which is carotid artery dissection. There are a couple of the things that tend to spring up with neck stuff, and particularly treatment approaches to the neck. Look at upper cervical instability and what it is and how we test it and whether it's worth testing it or not. And that's where the ligament testing come in. And then I think you need to know a little bit about headaches. Obviously you need to know about red flags, so we'll go through those. And then we'll start to look at the examination of the cervical spine. So that's kind of what I want to go through, if we can. So the clock is ticking. So really the burden of neck pain, if you look at the top 3 things, which is what we're going to do over these next few sessions, if you look at the top 3 things that you see in the clinic, it's going to be neck pain, back pain and shoulder pain. They're kind of like the top 3. If you work in areas specific, maybe you're going to see more pelvis and hip or what have you, but generally from a musculoskeletal outpatient setting, they would be the top three. And so neck pain is one of those top ones. It's fairly prevalent, so it depends on which research you look at, but adults 30 to 50% prevalence per year, children a bit more variable, and 5% of the global population. So there's this idea that an acute episode can become persistent, and like a lot of things that we do in physiotherapy or musculoskeletal health, we don't always get optimal outcomes. But yeah, persistence is quite high, from sort of around 40 to 80%. And there's research that says that a lot of people don't recover from an initial onset, and they go on to become quite chronic. And again, like a lot of what we do, outcomes for these people aren't always great. So usually, or not usually, but previously you could go to your GP and say, I've got some neck pain, and the GP would say, okay, don't worry about it, take some medication, it will resolve on its own. This is sort of a non-traumatic acute episode of neck pain. But I think, a lot of the evidence now, and like this is level 1 evidence, so you're talking about systematic reviews of randomised controlled trials, tends to show that that's not the case. So if someone gets an acute episode of neck pain, there's not a great chance that will just resolve and go away on its own, and that's previously what we've been told to believe. And then 30% of those people will go on to develop chronic symptoms. Things that are sort of associated with recoveries. So better recoveries are generally associated with people that have better health. So if you've got lots of comorbid conditions and lots of other pain things going on, that's not going to look good for your prognosis. The shorter the duration of symptoms, obviously, and the absence of headaches, back pain, those other things. When you look at things that come out across research into people's prognosis, they're the ones that kind of stand out. Things that also stand out for like a less favourable prognosis are high disability at baseline, presence of other pain, they take sick leave, they're older, and they have some of the other psychological factors like they're fearful, they're catastrophising, they've got poor coping mechanisms. So early on in that kind of assessment, we probably should be looking at those sorts of things, and you probably have people doing some sort of questionnaires. Short form Arebro is a really good one to flag up, are there other things that I need to look at, because it looks at a wide variety.
Do you do that on the first visit? Or?
Yeah, so when people come into my clinic, if I haven't seen them before, or even if it's a new episode and I haven't seen them for a while, they'll fill out a new patient information sheet, and then they'll fill out a short form Arebro.
Yeah.
And the short form Arebro, it's 10 or 11 questions, and it goes through what their pain levels are like, how long they've had it, whether they've got anxiety or depression, if they're fearful it's going to become persistent, whether pain means that they should stop what they're doing, all these sorts of things that can kind of give you pointers as to whether there's other things at play.
Yeah.
And you can get like a cut off there. It's the short form scored out 100. Generally, if they're over 50, that's like a less favourable prognosis, and it can highlight things there like they're not sleeping or other comorbid factors.
Yeah.
I tried to give it to people like
We've been in discussion at that.
Yeah.
Do you freak them out in the waiting room, or you should be asking those questions, or should you use that bit of validated research and just hone in? So we needed you to
I
guide us.
experimented with seeing them first and then getting them to fill it out, and I got the impression that doing it that way around, people were thinking that I'd made a judgment about them already. So they come in, I've chatted to them, I've gone, you're mental, please fill out this, and
It's
just
all in his
clarify
head.
that I'm right in thinking you're mental. Whereas when they come in and they haven't seen me and they don't know, oh, here's a screening questionnaire, or what's that about? Yeah, so
Right.
that's what I get them to do it first thing across the board.
Yeah.
And then other things like your neck disability index, you can do depression and anxiety, stress scales. Those other things can be done like after. If they've gone like, I've scored 8 out of 10 on depression or anxiety, and they've opened a conversation about that, then I say, look, is this a problem for you? Blah blah blah. Are you seeing anyone? How's it being managed? Is your GP aware? Blah 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 blah. And I talk to them about how that might relate to their prognosis or their pain levels, then I think they're quite open to going, do you mind if we do another screening tool on that, or blah, 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 blah. Whereas I think if you start doing those other ones early on, you might freak them out.
But you love the short form of Arebra.
Short form of Arebra, I think it's really good, and I always go, what did you think of this? And they'll say, that's fine, and I'll say the reason that I've got that is because I want to know how this is affecting you as a person. So that's important, because that is a good, like if that flags up straight away, you want to be going, that might be something that I need to address, you know, either by education and really reassuring them, or do I need to speak to the GP? Do we need to get clinical psych involved? Do we need to get occupational therapy involved, or something else? You know, for a lot of people, it won't be just I've got a sore neck and, you know, they score low on that, but for people, you will see that. And you'll wonder why, if you're just pushing on them and doing this and they're not getting better. Well, that's the reason. When we look at treatment, and we'll talk more about this at the next session, you know, research is all over the place with what works and what doesn't work. And the difficulty with research is that you're often investigating at a population level. So, you know, the bigger the population, the bigger the sample, the better the research apparently. But you'll get people that respond really well to a treatment, and you'll get people that don't respond very well to a treatment, and you'll get people that are in the middle, and that will just wash out all your statistics. So sometimes, like smaller case studies and pilot studies can often give you a bit better information around that. I know part of my master's with a guy called Jon Wray, he was doing his PhD into low back pain, and he tried to subgroup people into, you know, oh, these ones have got movement disorders, these ones have got sensitivity disorders, these ones have got psych issues, and blah, 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 and could you subgroup them? And he came up with about 30 different subgroups. And it's the reality is that that doesn't get done. And the more you look for differences in subgroups, the more you'll find. And so it gets harder and harder to treat. But what that does say is that multimodal physiotherapy is actually better. So, you know, using manual therapy, using exercise, using education and advice, changing habitual things and what have you can actually really help. If you look at a lot of the stuff on longer term sort of issues, exercise does seem to come out on top, and I wonder if we're that good at that bit. Did I send you that Sean O'Leary paper? Was that one that I sent you?
Yeah, about the cervical neck exercises.
Yeah. So, you know, a lot of that is done on whiplash. So that's a sort of post-traumatic kind of neck pain. But they've also seen it in idiopathic, so it just comes on for whatever reason. And you'll get changes, due to the pain, you'll get changes in how the muscle fibre actually happens around the neck, and it will change. So their postural, slower twitch fibres will change to a faster twitch, sort of prime mover type of architecture, and that's when they're getting, you know, muscle guarding and lack of segmental control and these sorts of things. So I'm not sure we do that very well. I don't think I did that very well. And, you know, in the last couple of years of going through specialisation, I think I've got better at that. But I think generally we probably don't do that as well. We know that manual therapy is effective for acute and subacute neck pain. It has a pain relieving effect, and I can send you some more research out about that when we do the next session. But, you know, it changes people's pressure pain threshold and heat pain sensation and things like that from manual therapy. If you can change people's movement evoked pain, so if they've got pain when they turn their head, you know, they'll already start setting themselves up for some preemptive pain, and that's the deep processing in their brain. So they'll already be anticipating pain when they move. If you can change that, you can actually start to change some of those pain behaviours and pain patterns and the sensitivity. We know it's more effective than what I talked about before, GP care for relieving, you know, neck pain. Go to your GP, they'll say take some paracetamol, anti-inflammatories, come back to you in 2 weeks. Might work, it might not. They'll possibly go on to become persistent. So we know that providing manual therapy and getting pain relief quickly and sort of fairly early can help people. And I did a case study on radiculopathy. So neck and arm pain due to nerve root compromise. And if you look at the research around, there's quite a lot of research that actually works quite well.
That's the article I had in the staff room.
Yeah. So when you provide someone with manual therapy, neural tissue mobilisation, those sorts of things, they can actually do quite well, you know, as opposed to just sending everyone off for surgery or cortisone injections. Now, red flags around the neck. Kind of look at it like this. It's either going to be a fracture, it's either going to be a tumour, they've got some sort of cervical vertebral instability or carotid artery dissection. They're kind of like the main things that you probably think that were a bit flaggy. For something like a fracture, you'd probably expect a history of trauma. For something like a tumour, you'd probably expect maybe or maybe not to have other signs of sort of ill health that may lead you down that sort of route. But we'll talk about that in a bit more depth later on. So for sort of non-traumatic neck pains, this sort of idiopathic neck pain that just comes on for one reason or another, I'll sort of break it down into this sort of approach really. So it's motor, articular or sensory, or a combination of those things. So when I'm talking about motor, it would be those changes in the muscular system. When you talk about articular, it could be like some sort of joint sign or restriction, that's, you know, like a facet arthropathy or something. And sensory would be, you know, these people that knowing where their head and neck is in space is not as optimal as it could be for one reason or another. From a
And you separate that out from motor.
Well, they're all going to interrelate at some level. It's just like which one is the most dominant picture, and sensory. And sensory can also be people that have a hyperalgesic. So they feel pain in their neck more than someone who's not hyperalgesic. And you see that, and we'll talk about that in a little while, you see that with things like migraine.
Yeah.
So people that have migraine, like this strong correlation with neck pain, even when there's no neck pathology. And so they wonder, is that just a wind up of the nervous system? So these people are super sensitive, and so they'll report neck pain that can be between migraine episodes or part of a migraine episode. Neuro, it's really peripheral or central. It's either this side of the dorsal root ganglion or it's that side, and then you're looking at, you know, what that involves. That's sort of a non-traumatic. If it's traumatic, this is probably taken from a whiplash. Well, this is the Whiplash Quebec Task Force classification of whiplash. So whether that's from a motor vehicle, whether it's from being bumped in footing and thrown over to the ground, or whatever it is, there's a classification system. That would be something worth looking at. You know, 0, why are they in the clinic? 1 is just neck pain, 2 is neck pain and, you know, changes in range of movement. 3 is with some neural signs, and 4 is like, well, you know, they probably should be in the ED. And that would be more your traumatic sort of approach. So that's kind of like an overview of neck pain. If you look at the anatomy of the neck, it's pretty much split into 3 distinct areas, and they're called typical or atypical. So C1 to C2, or sorry, C0 to C2 and C7 are considered atypical because the other bits operate fairly similar. Yeah, and that's to do with...
So C0 is the occipital.
Yeah, sorry,
Okay.
yeah, from the skull. So where the skull
That's
sits on
yeah.
C1 is considered C01.
Yeah.
Where C1 sits on 2 is considered C02. So, I don't know if I can get my... oh yeah. So, the skull would sit, obviously, in that bit. So we haven't got C0 on there. And it's to do with the way they behave when they move and their movement patterns. You can sort of see, and we'll talk about it in a little bit more detail, but you can sort of see the shape of the joint, or the joint orientation here and the joint orientation there. It's different, and we'll look at that in a minute. C7 is probably a little bit more closely related to the thoracic vertebrae. So it's got a much bigger spinous process. It's starting to get the transverse processes coming out, and sometimes you'll get a cervical rib off of there in a small number of the population. So that's why that's considered atypical. And then C3 down to C6, 7, they all kind of behave in the same way, and that's a little bit what that bobbed up paper was talking about. And I'll come back to that, because there's a couple of key things out of that paper which I got from it is worth knowing. If we look at it from the front, so the left hand sort of picture, you can see C1 sitting on C2 and vice versa all the way down. But you've also, we often talk about the facet joints, which are back here. You can see the outline a bit blurry. But at the front, you've got these processes, which is the unkinate processes, and they form a joint, sort of a vague joint at the front, which is called the uncovertebral joint. And there's another slide that sort of talks about.
I've never considered that.
No.
Yeah, no, we don't. But I'll explain why that might be something worth thinking about. So just guide some of the movement. The facet joint's probably the one that we think about the most. If we look at the different vertebrae, so from C1 at the top to C7 down at the bottom right, you can kind of see some of those differences. So C1 has these sort of like very cup-shaped sort of articular depressions on top of it to receive the condyles of the skull. So it's like a rocking chair that sits in there. And you can see C2, and you can see it on that side, has the dens which sticks up, which is like a projection like that, and C1 sits over it and rotates around it. And then the other ones all the way down, you can see, can be quite a good landmark, is that there's a anterior tubercle, a parietal tubercle on C6 that you can feel anteriorly on the left. And then all of them have got that foramen for the vertebral artery to go through. And we know that the vertebral artery, I'll step back a slide. We know that the vertebral artery, as it comes up through C2, it sort of makes this sharp bend back and up to go up through the foramen magnum and into the brain. Okay. So it sort of comes up and it goes back and around, and that's why when we're looking at checking for EBI, we're trying to stress that. Have you got a spine here?
Yeah.
Meg? We'll look at that. So I think getting those sorts of things clear in your mind with practice is a good idea, because that's how you're going to treat. Yeah, so if you look at, as it comes up through C2, it makes this sort of turn back to come around and under and up through the foramen magnum there. Yeah, and so when we talk about stressing that, that's where we look at the rotations. There's C1 at the top, looking down on it. There's looking at it from the front view underneath, that you'll see these are like little shallow depressions which the condyles of the head will sit on top. So when we look at movement of C1 and 2, I'll talk about that a little bit more in a minute, it's restricted by those joint positions and those joint alignments.
I like your rocking chair description.
Yeah. There's C2, and the terms that they use is that C2 is the axis, and C1 is the atlas, and it often gets a bit confusing, so we can interchange them. I like using C1 and C2. So you can see, like C2, if C1 is the ring that kind of sits down over that, this is sort of the shape of the joints that C2 makes with C1, so it's much flatter, so you'll see that it's more biased to a rotation than it is to other movement. So when you look at kind of movement of the spine, when someone's looking down, bending their head forward, those joints sort of slide forward in the main part of the spine, and the joints sort of stretch and open up, so you can see if your facet joints are kind of aligned like this, then the top vertebrae is going to sort of move forward and superiorly on the bottom one, and stuff at the front comes on off stretch, and stuff at the back goes on stretch. Yeah, does that make sense? Mm-hmm. And if you go back, the opposite happens, so the top vertebrae will slide down on the one below, and it sort of close down and slide down inferiorly. So that's kind of like from C2 down to C7. The occiput and C1 to are relatively different as well. So that's quite key to getting clear in your mind. Is that the occiput? So because of the shape of the occiput sitting like a rocking chair bottom in on C1, most of that movement is going to be in that sagittal plane, a nodding type of movement. C1, C2 having a very flat kind of articulation is going to be mostly rotation. And then when we assess it, we can bias what we're assessing based on that. The rest of the spine sort of follows what we've looked at there. When you look at rotation, for your typical joints built from C2 down, again, you're going to get this, the angle of the facets is sort of, not flat in the typical vertebrae. So when you rotate, if you rotate to the left, as in this position, the top one's going to slide down and inferiorly on the one underneath. Yeah? We call that a down slope. So it's going down the slope. Yeah. If you side bend, it's the same movement. So they share a common movement. So side bending is going to make the top one slide down on the one below. So that down and inferior. Does that make sense?
Mm-hmm. So do the two correlate nicely, do you think?
Yeah, pretty much.
And so therefore, I never assess side flexion because I figure I get what I want out of rotation.
You can. Sometimes one can be more provocative than the other.
Yeah, okay.
Yeah. And so if you really want to, so if you go, okay, they've got pain on this side when they rotate, is that sliding down in the cervical spine possibly? Or they've got pain on that side when they side flex, yeah, so that sort of ticks that box as well. And they've got pain when they extend, and it all reproduces that pain. You could sort of go, is there like a closing down pattern here that's not working well or is provocative? Is everyone clear with that? Because I think that's
that's how we
we
work.
treat
Yeah.
with down slopes here.
yeah. And so we've got a spine like mine, doesn't move very much, but like rotation is sliding down that way, side bending sliding down that way, and extending sliding down that way.
Yeah.
And then going the other way, rotation contralaterally sliding up, side flexion contralaterally will be sliding up, and flexion will be sliding up. So it's just the opposite in the typical part of the cervical spine. So what does that mean for other structures around there? So you can see this slide, you're looking up, side bending or closing down, that joint's going to compress, and the space between the joints, the foraminal space which other structures sit in, will be less. If you're opening up or upsloping, that joint's going to stretch and that foraminal space is going to open. Yeah, pretty happy with that?
Mm-hmm.
So then, that's sort of an overview of the different regions and how they work. So if you look at the Atlanto occipital joint, so where the head sits on C1, flexion 5 degrees, extension 10 degrees. Anything else is sort of a bit negligible. You've got a little bit of side flexion, but not much. So you've got a little bit of maybe that, but you've got more of that and a bit more of that and almost none of that. Yeah. If you look at C1 on C2, so Atlanto axial joint, there's a little bit of flexion, not much. There's a little bit of extension. Oh, sorry.
Yeah.
Yeah, there's a little bit of extension, but by far and away the biggest range of movement is in rotation. So if you look at that, 35 to 40 degrees of rotation is at C1, 2. So if someone can't turn their head, you'd have to be going, is that C1, 2? So if they come in and like that, can't move. So I had a lady on one of my specialist exams that was like that. She was this old lady and it was like that. That's likely Atlanto axial osteoarthritis. Long history of it. Wasn't getting better. Been stiff for years and years and years. And I think she had an X-ray that showed that as well. So like that. Yeah, that's C1, 2 restriction. Can you change that? I don't know. Maybe.
What did you do?
What did I do?
You passed his exam.
I panicked because that was a mock exam. I did it with a guy in Melbourne who that's what he does. He does all the facial pain, and he's an absolute gun. And he just rinsed me. But it was a really good learning process.
Yeah.
It's like that. It's really uncomfortable for me to watch people treat people with horror facial pain and neck pain because that's my thing. He's a specialist in that, and he said, "But you know, you did okay."
So what did you do?
I gave us
Did you mobilise it?
I did a mini treatment on it to see if it would change, and it didn't change.
Okay.
And then so the rest of it was about not much you can do in one session. There's a bit on just very simple exercise to stop her getting lots of muscle tone around there and creating more compression and restriction. If you look at C2 down, then you've got this combination of stuff going on. So flexion and extension and rotation. Interesting, from C2 down, you've got about the same as C1, 2. So that's how you can kind of pick the movement out.
So you're thinking that it's C1, 2 for the first 35, 40, and then it becomes...
Not necessarily. If I've got someone that's very restricted in rotation, I'll want to clear C1, 2.
Okay.
And I will be hunting that area. But you can get people that are,
good at C1, 2, but then terrible.
And terrible below that.
Okay.
And so they're getting, pain in the vision. So it just, that's kind of like the key point from the previous slides, is you can bias your assessment based on what you're trying to look for. Does that sort of make sense for everyone? Because I think that's really key. And if you do that really well, the rest of it's actually quite easy. From that bulk duct paper, I didn't put it...
With C2 to C7, if someone had no movement at C1, 2, if they had good movement at C1, 2, and they're restricted in the lower segments, could they still get
they're the
80 or
people,
9?
They're the people that would get to like 50, 60 degrees and they go, yeah, that's sore.
Yeah.
Or that's sore.
Okay.
They're not the people that would be like, unless it was really
So you tend to
comfortable.
find it's earlier range for C1, 2, and then...
Yeah, it can be, not always. That's why you've got to go looking to
Yeah.
prove or disprove what you're thinking. On that bulk duct paper, one of the key things that I wanted to highlight, and I probably should have put on a slide for you, is when you look at the mechanics of the cervical spine, the loading across the cervical spine is not equal.
Yeah.
So you tend to get more loading C5, 6, C6, 7. So when you're looking at issues with patients that have general neck pain, that would probably be a pretty good place to look, because that's where you're probably going to find 80%. That's just the way the neck is, and we're kind of designed to cope with it. And the thing with that is those changes, those joint changes. Like I reckon if you X-ray or MRI people in their 50s and 60s, you'll go, yes, changes at C5, 6, changes at C6, 7. That's like normal for most people. but it can set the stage then for an irritation or an acute flare-up because they can become sensitised
But
to
it's kind of the
something
same
else.
way as it's L45, L5S1, it's
Exactly.
C5667 just because of the anatomy.
The anatomy and the loading. And if those changes happen over time, most people cope and adapt quite well. If they happen more quickly or then they have a sudden event on top of that, that's when you tend to see some issues. So then if you start seeing nerve root irritation and these sorts of things, it will usually be at those levels as well.
Alright, perfect. We'll see you tomorrow at 11:30.
Now,
Thank you, bye.
Oh, and that's the other thing I was going to say, is that often they'll point to pain up here, but have pretty good rotation. And that often that's because down here is too stiff and not pulling its weight.
and they might be really
And so that they just pinch movement from wherever they can. And they often
Yeah.
come in with upper cervical
because it's doing more.
because it's overloading, but they don't necessarily have the upper cervical headache. It's just that pain because it's sort of lower cervical, just stuck.
Okay. Neurological exam. So really, if you look at a good neurological exam, that would probably cover a lot of your bases. The only thing that's not on there for the cervical spine would be cranial nerve stuff. But if you've got someone that's coming in and they're dizzy and this, that and the other and you're not comfortable with doing that, then that's, maybe time to get someone else to look at them. It's probably a little bit beyond what we want to go through now. But a good neurological exam, gait, Babinski, clonus. Hoffman's is a reflex in the upper limb on the fingers. And then obviously if you're doing a general neurological exam, you pick two main reflexes on the upper limb and two on the lower limb, and then myotomes and dermatomes. For the myotomes and dermatomes, I tend to follow the American Spine Injury Association guide because it's, and would look at that in the practical because it's easier, I think, to get a good screen.
Than the Australian, or
Say again, sorry.
easier than the,
What choices are there?
yeah.
Well, the standard assessment that if you've got someone that comes in with pins and needles, numbness, tingling, this, that, and the other, and you start going, is that C7, C8 because it's down here, or is it carpal tunnel? You've got to start going, is it here, is it here? Like looking at where the dermatomes are. If you look at dermatomes globally like that, they don't always pan out. They can be a bit here and here for certain things, so it's not always as we see on a dermatomal chart. The Asia, and I'll show you in a minute, for dermatomes just has key points. So it's like C5, C6, C7, C8, T1.
Oh, okay, I'm going to listen to that,
So you can just go like C3, C4, C5, C6, C7, T1. Sorry,
C8.
C7, C8, T1. And it's like, if there's changes in sensation to light touch or pinprick at those points compared to the other side, and it fits with the neck pain, blah, 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 you can go, right, I've got some sensation changes here. And you don't have to go, does it feel the same all the way around here and do that on that side? It's just too much, it's too hard. So that's why I try and keep it really
By
simple.
the time you get to the end.
Yeah, and they're like that, and you've got someone going, do that again. You're like that, and then you've done it slightly different pressure, and so they go, oh, that feels a bit more. It's just too much. Whereas if you're just stroking one spot, and then compare that to another spot, they go, that's different.
Yeah.
It's much less. And if that's different, that's different, that's different, that's different. It's not dermatome. But I pick it up now, whereas probably I would have missed it. I've picked up a few where you go, oh, that actually fits, and it's obvious. So yeah, VBI and CAD. So there's this whole controversy going on about whether we test this or whether we don't test this. You can't test for a carotid artery dissections. If someone's about to have a dissection, I don't think there's anything that you can really test that's going to prove or disprove whether that's going to happen.
When you say a dissection, just exactly what is...
So there'll be an injury to that blood vessel wall in one way or another.
Okay, so not actually...
And it can be spontaneous.
Well, we'll talk about that in a minute.
Okay.
But these are the ones that tend to come up post-manipulation. You know, someone saw someone and manipulated their neck, and the next thing they ended up in hospital with whatever. Yeah. So that's usually the carotid artery dissection. It can happen in the vertebral basilar sort of area, but that's commonly what you see in the media is that. So then there's this whole idea, so there's a guy in the UK called Roger Kerry, this is his bag, and he talks about we should give up this screening because it used to be like you put the screening in, if they're negative to it, you're
Just
safe.
turn the head to the side
Yeah,
for 15 seconds.
You're safe to manipulate or mobilise or what have you. And so there's arguments now that we should abandon that testing because it's proven to be not that specific and it doesn't rule out risk factors. So I think I sent you the iFont guidelines on manual therapy, so it's more about looking at people's cardiovascular risk profiles now.
Before, yeah.
Yeah, so if you've got someone with high blood pressure, poor cholesterol, blah, 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 blah,
History of
blah, blah,
smoking.
all those sorts of things, you could say that they've got a higher risk.
But you don't want to manip their neck.
For VBI, it tends to be in an older population. So, and that's where we get the 5 Ds and the 3 Ns. So they would probably come in saying, I feel a bit dizzy, or I feel a bit this, or I've got neck pain and dizziness, or what have you. And so you could test VBI if you felt comfortable doing it, and because you've got contralateral flow, you're actually checking their ability to provide contralateral flow. So if you put someone in an end of range rotation, which is the standard test, you're sort of stressing one side, or sorry, you'll stress one side, but you're actually checking their ability to continue to provide from the other side. So it's not really a pre-manipulative thing, it's are their symptoms related to that? Does that make sense?
I see, yeah.
Yeah, so someone comes in with neck pain and I'm dizzy and I've got these other things that are associated with that dizziness, like diplopia, double vision, dysarthria, which is problems speaking, dysphagia, which is problems swallowing, drop attacks, and spontaneous nystagmus. You know, you could go like, I'm not comfortable with that, send them on to ED, or they've got some of that, and you can go, okay, I'll check the VBI. It's not a test of I'm safe to manipulate or mobilise, and that's kind of where the arguments got in the literature with different people. On the other hand, carotid artery dissection tends to be in a younger population. Now, there's a woman on the East Coast called Lucy Thomas who's done a lot of retrospective studies into this, where she's looked at people that have presented with carotid artery dissection and then tried to reverse history take what's happened in their sort of profile. And usually, most of them are under 55. They've normally had this acute sudden onset of headache and neck pain, and when you talk headache, you're talking about thunderclap headache like nothing else that they've had. Preceding that, they would have some of this other stuff as well. Balance problems, gait problems, Horner's sign, which is when they get this sort of drooping of the eye. But preceding that, there have been highlighted in there minor trauma. Maybe a minor whiplash, maybe a minor fall, maybe some vigorous massage, maybe manipulation.
In like the weeks before.
Or at some point in leading up.
Just
to that.
in the shorter term.
So they may have things in their genetics that predisposes them to them. I don't think you can really, it's very, very rare, and I don't think we've got anything that screens us well enough to pick that up at the moment. Which is why, if all you do is manipulate necks, you've got a better chance of coming across someone than if you provide other treatments as well.
Megan might manipulate, but we don't.
Yeah, so this has been shown out, even people getting a hair off, putting their hair back over the thing has provided enough for them, or people that have been really ill with some sort of respiratory infection and cough, that may have been enough to set them up for something.
But it just comes down to the antenna goes up with a really, really sudden, nasty headache, and you just go, right, we need to
Yeah.
correlate
Well,
a few things going on here.
Yeah, and if they've got some of this other stuff, you're like, okay, that's a red flag, and you're off.
Yeah.
But it also highlights to us that we don't have anything that's good for screening this at the moment. You know,
Well,
as it-
but
as-
it's interesting with the VBI. Like, I mean, I've never manipulated anyone. I don't think over the age of 50, and it all happens in the older population.
and yet the more catastrophic stuff, the dissection, is in under 55.
Yeah.
It's interesting, isn't it?
Mm.
This is kind of like a combination of some of those. This is Lucy Thomas's work. So vertebral basilar artery dissection. So that's the artery going up that we know through the vertebral bodies, and the internal carotid artery dissection. They're kind of like if someone's having that happen and they're coming to see you, this is sort of the things that they commonly found. So headache for the VBAD, 85%. Dizziness, unsteadiness. So this is why a neurological exam is going to help you just make sure you're a bit safer. Obviously the internal carotid, they have this other stuff going on as well. So it is rare, we just need to be aware of it, I guess, as manutherapists. I'll send you the APA's position on it at the moment, and it's all taken from Lucy Thomas's work. If you look at iFont, she has something to do with that as well. How are we going for time? We're not too bad. Okay, we might just rip through this a little bit. Upper cervical instability. We've got ligaments up around the upper cervical spine that provide stability just like anywhere else in the body. You probably need to know about them. The ones that we look at are your alar ligaments, which prevent further rotation of the head on C2. We've got the tectoral membrane, which sort of supports the whole of the head on the neck, and we've got the transverse ligament. And the transverse ligament stops C1 sliding forward on C2. And so part of that testing is checking the opposite direction if it relieves symptoms as opposed to provoking it. So when you've got C1 C2 like that, C1 like that and C2 underneath with the dens like that, you've got the ligament running behind it.
Okay, so the dens at the front.
So
The dens comes up posteriorly? Yeah.
So you've got C1 sitting on that, and so the dens would poke up. You'd have C1 around there. The transverse ligament goes around the back of it. So this is the front. This is the back. Transverse ligament goes around the back, and it sort of acts as a bit of a rotation point, and it's sort of a joint, but it's not really because it's with a ligament. If that's gone, when someone puts their head forward, this slides forward, and then the dens pokes on the spinal cord.
And they kind of hold their head in their hands.
Yeah, when they put their head down, they'll get neurological symptoms of varying description.
Yeah.
And they have to support their head to do that. So when they do that, basically that's happening, and that dens is sliding onto the spine.
And is that often through in whiplash sort of injury? Is that
So,
or the RA?
Well, that does.
Both.
so rheumatoid arthritis is one, trauma is another one, and then you've got congenital abnormalities, Klippel-Feil syndrome, which is just like, it's a change in the way the cervical vertebrae develop from a young age. They're usually these people with quite a small neck. Down syndrome is another one.
What does that mean? Evidence damage 6 years after the injury.
MRI evidence of alar ligament tectoral membrane damage. So they've gone, someone's had a traumatic injury or what have you, and they've imaged them down the line and shown like they show signs that they've injured that.
Yeah, because so it'll be someone after like a nasty tackle in rugby or football, like contact sports, like getting dumped
Yeah.
on the beach, and rheumatoid arthritis.
Yeah. So definitely with people with rheumatoid arthritis, I'm quite careful about what I do up and around the upper cervical spine, because part of that rheumatoid process is the immune system is attacking all the structures around the joint, whereas osteoarthritis is like changes in the joint surfaces. Rheumatoid arthritis is the destruction of the capsule and the ligaments and all that stuff as well, and so they can develop this upper cervical instability. So end of range movement with them and really vigorous manual therapy is probably not the best thing to do. Happy?
Yeah.
So these are those three ligaments. I have got a video, and I'll probably show it to you next time maybe when I get it to embed in the presentation. I couldn't do it for some reason, but it shows that upper cervical spine slipping forward on someone through an MRI in real time as they're moving the head. So alar ligaments basically prevent over rotation. They come off the dens and up into the occiput, and they'll sort of get taut at the end
They're
of
out
rotation.
here.
And can you get one and not the other?
Yeah, you can.
So it would be quite obvious.
Yeah. And then you can get change, you can get subluxation of the
So more than
Joints.
90, you mean?
more than 90 rotation.
Mm.
But everyone's going to be a little bit different.
Yeah, but so
You're talking total.
What percentage difference would you see if one was busted and one wasn't?
You probably wouldn't pick it with that. You would pick it with your ligament testing.
Yeah. Okay.
Transverse ligament we've talked about stops the head moving forward on C2. Pectoral membranes, like this blending of a membrane that comes up the back of the neck and into the skull, multi-directional stability. So that's looking down, posterior, anterior, just to confuse you, it's the other way around. That's the transverse ligament. So if that's gone and someone looks down, this will slide forward and the spinal canal is there.
yeah.
And then they'll go, oh, come on, I've got pins and needles in my feet. And then you go, right, don't do that. And then you'll probably want to onward refer them. The alar ligaments you can see coming off like that, and they're going to restrict that rotation, isn't it? And then I haven't got the pectoral membrane, but that basically comes up and through the foramen
So
magnum.
can they stabilise that transverse ligament, like surgically?
So I
or
think
what
like
they
the
do?
first approach is to immobilise them, so there'd be in a collar,
Okay.
a hard collar for like 6 or 8 weeks.
Yeah.
Okay, happy so far?
Mhm.
I'm going to zip through this next bit. Headaches. Very common to get people with neck pain and headaches. Not all headaches are from the neck. So really they're classified as primary, secondary and cranial neuropathies. And cranial neuropathies would be things like cluster headaches and those sorts of things. Primary headache is where it's the headache. Secondary headache is where it's the headache. Secondary is something else. So, you know, if you're wearing a hat that's too tight, that could be a secondary headache. If you've come off of drinking coffee and you've got a headache, that's a secondary headache. If you're taking loads of paracetamol and now you're not, that's a secondary headache. Cervicogenic headache, where it's from the neck, would be considered a secondary headache. Things like migraine and tension type headache would be considered primary.
Is tension type not secondary to stress?
That can be a contributing factor,
Okay.
but the actual underlying mechanism is
Okay.
yeah.
Yep.
And it's the same with migraine. Yeah. So that's kind of how they're positioned. There's a whole classification. If you look at the International Headache Classification System, they've got to have so many features of each thing for you to think that they're one or the other. And we'll just really zip through. That's probably the most common that you see, tension type headache. That's the classification really of what a tension type headache is. So it's usually bilateral. It's usually this sense of pressing or tightening or what have you. They don't often say that it starts in the neck, but it might do. And they don't get both vomiting or nausea and phono or photophobia. It's the sensitivity to like something go one or the other. They usually can go about their day, and it's probably one of the most unreported ones because it's in a moderate to low score for their pain, and so it doesn't stop them doing anything.
And what is the cause of that exam?
That's a whole nother question, isn't it?
Okay.
Oh, sorry, migraine. Second most common headache. So that's usually short and intense, and if it's not treated, 72 hours probably, and this is the one where people go shut the doors, shut the windows, draw the curtains, lie on the bed, because they do get photophobia, they do get nausea and vomiting. It's usually one-sided, and it's moderate to severe, and they will stop what they're doing. Most people know if they've got a migraine. The thing with a lot of the research, and especially if you go to a neurologist, is migraine gets mixed up with a cervicogenic headache because their features are similar. And sorry, the migraine that we looked at there, that's a migraine without aura. If you've got a migraine with aura, then you're getting some neurological symptoms where visual's the most common one, but it's fully reversible. You can get ones that mimic stroke, you can get ones that mimic dizziness, but it's fully reversible. Cervicogenic headache is very similar to migraine, unilateral, but they normally say that it starts in the neck and refers into the head. They normally don't get the other things associated with it, but they will have things like it's triggered by certain movements, there's a restriction in a range, these sorts of things that tend to make you think it's a joint sign. So headache is a whole different thing, but we probably just want to be aware of it because cervicogenic headache is something that we might look at with our treatment. They're warning signs for headaches because it fits with the internal carotid and basilar artery dissection. Yeah, so they're things to be aware of. This thunderclap headache is probably the worst one, but if someone's not well and they've got a headache and it's just, you can tell that a person that just doesn't look great, and I'd always get the GP to check them out. Headaches that wake people up. There's very few headaches that wake people up. A cluster headache is one of them, and it's a sharp and intense headache, and it lasts 20 minutes or so. But that's one that will wake people up. So it normally comes on in the early hours. Red flags. There are main red flags. Cancer, Corticoinus syndrome, I guess it's more for the lower part, but you can have something from the neck based on myelopathies, inflammatory presentations, rheumatoid arthritis and other spondyloarthropathies, some sort of trauma and some kind of infection, TB, those sorts of things. How do we screen for red flags? I've got a couple more slides and then we're out of here. How do we screen for red flags? Well, if there's been trauma, we've got these rules generally. So for cervical spine, we've got the Canadian C-spine rules. For headache, we've got those things that we're looking at that are just a bit out of the ordinary. That's your Canadian C-spine rules. So if they've had some sort of traumatic event, that is like, how do I deal with that person? That's worth having a look at and going through. And remember, a lot of these Ottawa knee rules, Ottawa ankle rules, they said that you don't miss something. And so that's kind of gives you a bit of a guideline.
Yeah, that's good.
But the reality is, with red flags, so history of cancer, over 50 years old, and they've got neck or spinal pain and weight loss, that's a big red flag, because there's like a 90-something% chance that that's a metastasis. So you would go, like, I need to get that checked out before I start, doing this. But for a lot of the other things, they don't always present that way. This is Laura Finiconi's work. She comes up with this sort of levels of concern. And so, I think most of what we see is that half. No concerning features or a few concerning features. The odd one is like some concerning features and urgent referral, and then other ones like you need to go to ED now. I would say, I don't know about you, but I reckon I operate there, I see a few of them, and occasionally see that. Not very often.
Touch wood.
Yeah, yeah. So if they've got no concern features, just start treatment, doing something. If that doesn't respond how you would expect it to respond, then you've got to go, okay, I need to review this, is it something else? So having a really good treatment plan and following people up and making sure that you see them at certain time points is a really good idea. So, you know, I rarely see someone for 1 or 2 treatments, and even if I think I don't need to treat them in the following week or 2, I'll book a follow-up in like 3 or 4 weeks, because I want to make sure that my areas for concern are low, and then I can make that kind of call later on down the line, so you're looking at a bigger picture or longer periods of time. Few concerning features, you know, you're a bit more vigilant, you might want to make sure that you see them a bit more quickly. So acute lumbar spine, which is obviously a large disc injury, I want to go, like, I don't want that to turn into a cauda-equina syndrome, because that needs to be dealt with quickly, so I will see them more regularly over those first few weeks until it settles down. Yep. So we can't rule out 100% red flags, so this watchful waiting or levels of concern is kind of something we should be thinking about. And then these are our special questions. It's not perfect. There's a lot of talk in the literature about how useful it is and how good we are at picking up red flags even when there's other things involved. We can only do what we can do.
Well, we just did the pain thing on Clinical Edge, and we came to a consensus that we know what something on average looks like when it walks in the door. Yeah, and when it doesn't, like Annie had someone, what was in her eye? Was that shingles in her eye?
Shingles, yeah.
Shingles in her eye. I had somebody, which I haven't had a chance to talk about, with a vascular, he was in last time I treated him, he was running 18 Ks a year ago. And this time he came in and he got on the bed, and that contact with the bed hurt him. And that was a vascular inflammation-y thing that, you know, needed. When it just doesn't look right, that's when our antenna has to go up. We don't need to know what it is, but we need to know what normally walks in with back pain, and when it's markedly different, we've got to start asking questions.
Yeah.
And
I agree.
everyone's had a few just weird things that.
But I totally agree with you, and I think sometimes what I've seen in private practice when I've been going around is, you know, someone comes in the door for initial assessment, physio does a load of treatment on them, and then, okay, give me a call if you need me. You know, if it hasn't settled down by next week, give me a call. It's like, hang on a minute, I always want to follow someone up. Like, have I made them worse? Have I made them better? Are they going somewhere else, or are they a red flag that I haven't seen? So I think we just need to be aware of, okay, what's the usual sort of time frame or, you know, prognosis of something like this? You know, are they going to slowly get better? Are they going to slowly get worse? You know, what would I expect? And I want to keep an eye on that until I'm comfortable. And I don't over-treat people, but I don't under-treat, because I think that's probably just as bad. And so that's something that I think we need to be aware of. Everyone happy with that?
Yep, we've
Because now,
recently gone over it.
that's kind of what I'd like to go through. We've got 45 minutes, I guess,
Perfect.
to go through. So, neurological exam.
Are we going to move into room 2?
I reckon cervical spine, we'll probably break it down into the upper and sort of the rest. We'll look at ligament testing, but I think the jury's still out on that. Motion palpation, up slopes, down slopes, maybe some nerve palpation and some pain provocation techniques. Yep. So have you got 2 beds set up in
Yeah,
here?
2 beds are set up, and Kerry will take this way. If we could just take enough chair to save her and throw it into the reception. That will help her out a bit, and then we'll do our practice.
So before we go in, is there any questions on rattled through some of that just because I don't want to spend too much time. We've got next session. Has anyone got any questions from that? Or are you quite confident so far?
No, that's good. No, it's nice and consistent with what we do.
Yeah, that's good.
Is a great reminder of why. It's medial glide, C12. Down
Yes.
slope, C56. Cranky on one side, you can trick it by doing an upslope on the other.
I can do all that.
Where are we going?
Okay, cool. Into two.
I think that's. Megan, should we stop the video? Or does she want us to?
Do you reckon stop it?